Hello, and thanks for tuning in to this primer on electrocardiograms for pharmacists. My name is Zach Knoll, and I'm a clinical pharmacy specialist in cardiology and on faculty at the School of Pharmacy. And I was asked to put together this brief kind of tutorial, so to speak, with the primary goal, the primary purpose of helping you all more efficiently identify arrhythmias during critical situations or emergency situations. And so recognize that a lot of what I'm going to talk about is really to help you be a bit more confident in your abilities, help you know what you're looking at in terms of telemetry monitoring, and then ultimately be able to use your skill sets to identify the arrhythmia and, of course, come up with a treatment plan from there. So, in terms of the objectives, I want you to do a few main things. We're going to really focus on four arrhythmias, and those being atrial fibrillation, ventricular tachycardia, both monomorphic and polymorphic, and ventricular fibrillation. And we're going to use those arrhythmias to answer a couple of other questions related to them. And the goal is that you're going to make connections with what's happening on an electrical kind of, or from an electrical standpoint within the heart. And correlate that to what you're seeing on the ECG. And hopefully, if you can make that correlation and make that jump, it will make a little bit more sense to you. So it's my understanding you've had some prerequisite training, you've had your electrocardiogram class, you've had basic life support and advanced life support. Your future training is your PMERT training. And so I'm kind of bridging the gap, so to speak. And so that's what this brief video tutorial is going to be. There will be just a quick assessment at the end. I'll show you a QR code, and that will take you to the assessment that you can take. So we're going to focus on two main things. One, finding the tracing. And that might seem very silly, but what I find is that residents and pharmacists get a bit overwhelmed by the amount of information that they see on a telemetry monitor or a ZOL, and they kind of don't know where to start. And so I'm going to try and help you all walk through that. And then secondly, identify the rhythm. Find the tracing, identify the rhythm. Those are really the two main things that we're going to be focusing on. This latter part, the rhythm identification, you've already had some practice on, so I'm not going to belabor those points. All right, so I want to start by asking what's the difference in a 12-lead ECG versus telemetry monitoring versus ZOL monitoring? So I'm going to show you a picture of each of these, and we'll kind of walk through what some of the differences are. Before I talk about the 12-lead electrocardiogram, I want you to imagine that you go out to your vehicle and you're going to take pictures from various angles. You're going to take a picture of the front bumper, the back bumper, from both sides, maybe from up top, from underneath the car. Each of those pictures gives you the same thing, a picture of your car, right? But you're looking at it from a slightly different angle. And so while you're looking at your car still, you get slightly different information from each angle that you take the picture from. So too is a 12-lead electrocardiogram. You're still looking at the electrical activity of the heart, but you're looking at the heart at a different angle, so to speak. And so the 12-lead electrocardiogram gives us 12 different snapshots, and those 12 snapshots are highlighted on this top half of what you see here. You can see numbers 1, 2, 3, followed by some letters AVR, AVL, AVF, and then V1 on downward through V6 over here. Those are the different leads and the different snapshots that we're getting. Each one covers a time span of around 1.5 seconds on this electrocardiogram. If we direct our attention towards the bottom half of the electrocardiogram, we will see that there are 3 different leads that span the entirety of the electrocardiogram strip. So we get essentially a 10-second strip, so to speak. Now, going into the nuanced detail of how they get this and where the leads are placed and things like that, that's beyond what I want to do for this session. I've placed a resource at the end of the presentation if you want that information. What I want you to do is to think about essentially how you're going to train your brain when you're responding in emergency situations. And if you can train your brain to focus in on certain aspects of the 12-lead electrocardiogram or telemetry, etc., you're essentially going to take the amount of time that you're thinking or wondering, am I looking at the right thing? And then you're then able to take that time and spend it on identifying the rhythm. And so lead 2 is what I want to draw your attention to. Lead 2 is kind of the best overall electrical picture of the heart, so to speak. And so if you're able, finding lead 2 is usually kind of a safe place to nest, so to speak. And so if you can find lead 2, just direct your attention and focus on that for the rhythm identification portion. That's true for telemetry monitoring. That's true for the 12-lead electrocardiogram. All right, so how does that compare with telemetry monitoring? Well, telemetry monitoring typically has fewer leads, so usually we'll see somewhere in the order of 3 to 6 leads. Some will have 9 leads, just depending on the location. But the bottom line is it's not quite as robust as what we see with a 12 lead. However, we're able to monitor continuously, which is certainly an advantage. And so, again, as with the 12 lead electrocardiogram, you look at it and you're immediately overwhelmed by all of the lines and the letters and numbers. When you look at this telemetry monitoring, unless you do it on a routine basis, you're immediately overwhelmed by what you see. And so I just want to orient you to what we're looking at here. First things first, we're actually looking at the telemetry monitoring for 2 different rooms. If you look at the top here, you're going to see CCU bed 16, CCU bed 10. This picture was taken from a room where a nurse had 2 rooms, and in order to help keep an eye on both rooms, the nurse had both telemetry sets up on one monitor. This is actually a very common practice, and so the reason that I'm pointing this out is that I want you to recognize that there's a potential you could walk into the room, and if you aren't aware of this, you could be looking at the wrong patient's telemetry monitoring. And so just to orient yourself, know which room that you're going into and which room you're going to be looking at on the telemetry. Sometimes it's very obvious, right? If they're in asystole and flatlined, usually that's pretty easy to pick up on. But I just want you to recognize there are times where you will see 2 different telemetry monitors on one screen. So from here, what I want to orient you to is the electrocardiogram tracing, of course. And so if you look at the green at the top here, usually the green tracing is the ECG tracing. So that's usually a pretty quick and easy way to identify it. We see that on the right, we have lead 2 and V1. On the left, we have V2 and V5. As I said on the previous slide, orient yourself to lead 2 and block everything else out. Just kind of focus in on lead 2 and doing the rhythm identification that way. And so recognize that these leads might change depending on the way that they have the telemetry monitoring set up, but usually lead 2 is present. And so other waveforms that you're going to see on the screen, we have oxygen monitoring, we have respiratory rate. If they have an arterial line, you're going to see a red waveform that matches the arterial line. Do your best to tune that out, at least when it comes to the rhythm identification. I'm not saying that knowing the oxygen saturation isn't important, but what I am saying is that when pharmacists and residents get thrown into these emergency situations, oftentimes there are so many things going on that they really focus to kind of train their brain and really just focus on the rhythm itself. And so if you're able to block the other things out and just focus in on lead 2, I think it will help you in identifying the rhythm and coming up with a treatment approach from there. The last one that I'll show you is the ZOL monitoring. And so ZOL monitoring is going to be even less robust in terms of kind of the number of angles of the heart that we're looking at, right? We're usually just looking at a couple of angles. The electrocardiogram tracing is at the top here. And so really just direct your attention to that and you should be able to see the tracing that way. At the bottom here, and this will vary depending on which ZOL monitoring you're looking at. This one shows a waveform for CPR, but again, do your best to kind of block some of the, filter out some of the other things and really just focus in on the ECG tracing. So as you go about your PMERT training, as you go about getting experience with this, remember the first thing you have to do is know what you're looking at. And so as you're going into a situation, train your brain to really focus in on that ECG tracing, have confidence in what you're looking at, and then from there you can focus on some of the other information. This really just recaps what I told you already. When you find the ECG tracing or when you're looking for it, it's usually one of the green tracings. Now, I don't want to say always because there are exceptions, particularly on some of the telemetry monitors if you're doing remote monitoring, but actually in the room, telemetry monitoring is usually green as well. Don't get distracted by other waveforms. I already talked about that as well. So the second part of this is identifying the rhythm. To be honest, there are really just 3 very simple, straightforward questions that you need to ask yourself when you're identifying the rhythm. Is it fast or slow? Is it regular or irregular? And is it wide or narrow? The fast or slow part, I'm not going to cover in this because it's, I think, what we're probably most comfortable with. I want to focus on the regular or irregular and the wide or the narrow QRS complex. And I want to do this again by asking a couple of questions. What distinguishes an arrhythmia that is regular versus one that is irregular? You might be thinking, well, isn't every arrhythmia by definition irregular? Yes, to an extent, but what we're really getting at here is the distance between the QRS complexes. Let me illustrate this using a very common arrhythmia that you'll no doubt see, that being AFib. So in atrial fibrillation, if we were to measure the distance, which of course the x-axis is looking at time, so if we were to measure the time between one QRS interval and the next, and we were to do that throughout this ECG strip, we would see that it varies significantly with time. You can see 600 milliseconds versus 560 versus 700. And so this is really what's defining the irregularity, so to speak. It's that the distance between the QRS complex varies with time. And that's why we call this an irregular rhythm, right? Not only is it irregular, but it's irregularly irregular. It's constantly changing with time. Now, this is it's much easier to see when the rate is this, as opposed to if it's a very fast rate. Let's say you have AFib at a rate of 150. Well, it can be very difficult to discern those kind of small millisecond differences between each QRS complex. And so there's more to it than just what I'm showing you here. We can also look to see if there are any discernible P waves. That's another kind of characteristic part of AFib, is that you can see no discernible P waves. So the other aspect that I want to kind of, again, comparing these arrhythmias is if you look at this, which is monomorphic VT, if we look at the interval between each of the QRS complexes, what you're going to see is that they're very similar. And so I've shown you this simply because I want you to, or I want to compare the differences between AFib and, for example, monomorphic VT, which is a regular arrhythmia. And by regular, I simply mean the time between the QRS complexes. So what produces this in AFib? This is part of the correlation aspect that I hope you'll understand at the end of the video presentation. At the end of the day, we have what some have referred to as our best friend bodyguard of the heart, so to speak, and that's the AV node. The AV node is our best friend bodyguard because it protects the ventricles from impulses that originate in the atria. Certainly it allows some through, but it protects the ventricles from too many electrical impulses. And recognize that within AFib, we have electrical impulses that could be originating from all over the heart, and we know that they are coming in at a rate of 600 plus impulses per minute. The AV node has a built-in refractoriness to it, and that refractoriness essentially allows it to punt away impulses that are too fast and should not be going to the ventricle. But the reality is that the AV node is being inundated with these impulses incessantly. And so as the AV node comes out of its refractory period, it allows an impulse to pass through the rest of the conduction system into the ventricles at kind of varying time points. And so it's that situation that produces the irregularity that we see in an electrocardiogram. So again, my hope here is that you make the connection. I want you to understand the why behind the irregularity, because I think if you understand that why, so to speak, it will make more sense when you're trying to identify the rhythm. The next question I want to ask is, for wide complex arrhythmias, what makes the QRS complex wide? Again, it might, to some of you, seem like a very straightforward question. To others, you might be, well, I don't know. I've never really thought about it. So I've shown you a picture of what is very classically torsade de points. We see the twisting of the points, so to speak, on the electrocardiogram strip that I've shown you here. And so why is it that the QRS complex is wide? So if we take our picture of the electrical system again, recall that once the impulse comes to the AV node, there's a brief pause, and then it will go through the bundle of His to the left and to the right bundle branches, and then it's going to go out to the Purkinje fibers. And from there, it goes to the individual myocytes and produces this very kind of succinct, uniform depolarization, which manifests as a narrow QRS complex. Recall that along the x-axis of an electrocardiogram, we're looking at time. And so if the depolarization happens very quickly and all at once, well, it's going to be a short amount of time, and it's going to be a narrow QRS complex. I refer to the electrical conduction of the heart to be kind of the highway system, so to speak. But if, for example, the impulse originated somewhere else within the myocardium, outside of the normal conduction system, it's then going to kind of slowly depolarize the other cells within the ventricular myocardium. And that kind of slow wave of depolarization outside of the normal highway system, it's kind of the back road, so to speak, is going to produce a much wider QRS complex. Why? Because remember, we're looking at time along the x-axis of the ECG. And if it takes longer to depolarize both ventricles, it's going to take longer for that QRS complex to complete. And so that is, in essence, what's producing the wide QRS complex. If we were to look at this bottom figure, which is showing you the ventricular myocyte depolarization, we see a very rapid phase 0 upstroke here during the depolarization process. And then, of course, it comes down and repolarizes. And we see how that correlates with the QRS complex. But in a situation where we have a monomorphic or polymorphic VT, what we might see instead is this slow depolarization that occurs, and then the repolarization is delayed some too. And this would manifest, again, as a wide QRS complex because we're looking at time here. And the longer time it takes to depolarize, the wider that QRS complex is. Why am I belaboring this? Because obviously recognizing wide QRS complex arrhythmias is a really important part of ACLS and emergency response. And so if you can identify this quickly and you're able to deliver therapies more quickly, obviously that is a good thing. So I want to recap here by going through the 4 main arrhythmias that we've talked about, or 3 of the main ones we've talked about, and then also ventricular fibrillation. So recognize that within atrial fibrillation, we're going to see variability between each QRS complex. It's going to change constantly with time, which is why it's termed irregularly irregular. And there are also no discernible P waves within AFib. We just see this kind of fine fibrillation, so to speak. And so those are the characteristics of atrial fibrillation. In terms of monomorphic ventricular tachycardia, it's called monomorphic because the morphology of this QRS complex is unchanging over time. We see a very consistent tombstone-like appearance. It is a regular rhythm, regular in the sense that the time between the QRS complexes is the same, which of course we contrasted to atrial fibrillation. Polymorphic VT is constantly changing with time, and that QRS morphology, as you can see, gets smaller, gets wider, so on and so forth. Recognize that torsade de pointes is a type of polymorphic VT. Not every polymorphic VT is torsade. So you're not always going to see this classic twisting of the points picture that I've shown you here. There are various types of polymorphic VT where it doesn't have this classic twisting of the points appearance. And then lastly is ventricular fibrillation. I haven't talked about this up to this point, but it looks very similar to what we see up here with atrial fibrillation, at least in terms of what the atria are doing. It's analogous to what the ventricles are doing in VFib, which is really just this fine oscillation with no real contraction or forward blood flow. And so recognizing the differences here, right, we don't really see any QRS complexes on the bottom, whereas on the top with atrial fibrillation, we at least see those QRS complexes. We don't see that with ventricular fibrillation. So these are the 4 main arrhythmias that I wanted to focus on in this presentation and that we'll be assessed on. So to recap, I hope that you'll kind of train your brain, so to speak. Find the tracing and be confident in that. That's kind of takes a little bit of training to go into a situation and to train your mind. Okay, I'm not going to focus on all of the kind of superfluous information, so to speak. I'm going to focus in on what I need to make an assessment and come up with a treatment plan, so to speak. And then secondly, identify the rhythm. And we asked just a three very short, quick, and simple questions. Is it fast or slow? Is it regular or irregular? And is it wide or narrow? And I think if you can walk through this kind of process in your mind and throughout your training, it will help to kind of ingrain this process. A couple closing thoughts. One is reflection is a form of practice. Why am I saying this, and what does it mean? Um, what I mean is, many of you are going to be put into these emergency situations where you maybe need to identify an arrhythmia acutely, and then you might not be forced into that situation for many months to come. Reflecting on how you respond to the situation and periodically coming back to that in between those long gaps, so to speak, is actually a really effective form of practice. And so, walking through kind of step by step what you're doing as you enter the room, where your eyes are going to look on the monitor, what your kind of stepwise approach will be to identify the arrhythmia, and then, of course, from there, coming up with a treatment strategy, what drugs you need, whether or not a shock needs to be delivered, etc. Walking through that very deliberately in your mind from time to time is actually a really effective form of practice. And so I hope you'll do that, especially if you're in a situation where you really don't respond to emergencies all too often. If you want additional information on some of the concepts that we talked about and maybe piecing things together in a bit more detail, I've provided a reference here for a recent AJHP article that covers the basics of electrocardiogram interpretation for pharmacists. With that, you can scan the QR code to take the assessment, and you should receive immediate feedback as you take the assessment. If you have any questions, please let me know. And otherwise, you should be good to go. Thanks for tuning in.